A very big hello to all my dear students. So let's start with conjunctiva. Conjunctiva, what are the topics we are going to cover? Let's have an overview here. So we'll be talking about the different types of conjunctivitis. We are going to talk about a very important infective conjunctivitis, that is trachoma, ophthalmia neonatorum. Then we talk about allergic conjunctivitis and its different types. Then of course pterygium, pinguicula, dry eye and so on, right? So let's start. What is conjunctiva? It's a thin mucous membrane covering the ocular surface, right? So this is very important. It's a thin mucous membrane, right, covering the ocular surface. You divide it into three parts. We all know that. What are the three parts? It is bulbar conjunctiva, then the fold is fornix, and then comes your palpebral conjunctiva. Under the lids, palpebral. Bulbar just in front of the eye, that is on the scleral part. Of course, it does not cover the cornea, so it is stopping at the limbus, right? That is bulbar. Let's have a look. So now you know the three parts. Let's be more clear about what are the different three parts of the conjunctiva. So this is your palpebral, which is under the lid, right? And then of course, this is your bulbar conjunctiva, and this fold is what is called fornix. Clear? Right. So can we draw it in our own style? What is just a very oversimplified diagram, of course. So we'll make these are the lids. This is your cornea. So this becomes your limbus. Here we are showing the pupil, right? So we are saying this is your bulbar conjunctiva, correct? Right. Then it, of course, it reflects. It first makes a fold here, which is called fornix, and then comes your under the lids, and just under the lids, this one becomes your palpebral. I really want you all to please make these diagrams, okay? So this is palpebral conjunct. You are going to have a very quick revision possible if you are making all the diagrams along with me, right? And of course, noting down all the questions that I am going to mention, Qs and double Qs. So conjunctiva seems to be a very simple chapter. It is mainly factual, right? So, but what is very important to understand here is that a lot of questions are asked in your PG entrance or in your FMG exams, in all your entrance exams, right? So it becomes an important chapter anyway, right? Okay, so this is your bulbar, this is fornix, and this becomes your palpebral conjunctiva, not very difficult. And of course, I hope, let me remind you this, just above the sclera is not bulbar conjunctiva. What did we learn? Above the sclera is episclera, then comes a Tennant's capsule, and then comes your conjunctiva. Take? Okay. What is fornix also known as? What is fornix is also known as is cul-de-sac. Okay. This is the other name of the fornix. This is what we call as cul-de-sac. Right. Okay. Then what is this tissue? What is this tissue? Here. This is what is called caruncle, right? Caruncle is this again is containing, there are 2 points. One, of course, the NLD, it is already written here. The nasolacrimal duct passes through it, and it contains goblet cells, okay? Contains goblet cells, right? And can you see this fold of the tissue? And this is what is called plica seminularis. So you have to understand this is all a part of conjunctiva only, okay? This is almost analogous to the nictitating membrane for lower animals, right? Now, this tear film that is formed, which collects at this area, that is what is called lacus lacrimalis. Now, this of course has not been asked, but we have to know this. It's very simple. Okay? So, after this we come to next important thing in anatomy is we have to keep in mind. Let's see, have a look at this one. So, we know this is the lid and the different parts of conjunctiva is being shown. What is important? What is bulbar conjunctiva? Again, we are repeating, this is the fornix and this is the palpebral. The color coding is in front of you. And of course, this is just the surface of the cornea which is being shown here, right? And then we talk about in the fornix, what we have are accessory lacrimal glands. The main lacrimal gland everybody knows is on the outer upper quadrant. So, in the fornix area, we have accessory lacrimal glands. What are the names? Glands of Cross, glands of Wolfram. Okay, we will remember that. And in the lids, of course, there is meibomian gland. Okay, what next in anatomy? We have to know, okay, this we have mentioned. We have to know that how many fornices are there. So, do not say only upper and lower, we have 4 fornices, okay. Superior, okay, then we have lateral and medial as well, apart from superior and inferior. Now, what is very, very important, and we can note it down here, is that superior is fornix is most deepest of all. Okay. So, this is the deepest of all. Sometimes what happens due to disinsertion of the levator palpebral superioris in old age, when there is disinsertion of LPS. Okay, I hope you are noting down. What happens? You get a very voluminous, so we have to learn some clinical applications along with anatomy, right? So, you get a very voluminous fornix. Superior fornix becomes very voluminous. And we are talking about superior fornix, and this is what is called giant fornix syndrome. Okay. So, giant fornix syndrome is something like this, as you have a look here. So, this occurs in old age, and what is the main problem? Common sense. The foreign body can get lodged inside this and can trouble the patient, right? Okay. So, the foreign body gets trapped here. Right. So, what next? We next talk about palpebral conjunctiva. We already know palpebral conjunctiva means part of the conjunctiva under the lid. Now, let us talk about the different parts of palpebral. First, we are making this diagram in my style to make it simple. If this is the tarsal plate, right, and this is your lid margin. So, if I show you the whole lid like this, palpebral is under the lids. So, the part which is covering the margin of the lid becomes your marginal, okay, part of the palpebral conjunctiva, whereas this becomes over the tarsal part, and just behind the tarsal, the part of the conjunctiva is called orbital part. So, there are three parts of the palpebral conjunctiva that you have to know. And fourth, very important, where the marginal and tarsal, this junction, here there is a little sulcus out here, okay, and this sulcus is what is called sulcus subtarsalis. Do you understand? Think about your lid. So, if this is the margin, just where it is starting, the tarsal part is starting, there is a little bit of groove. That groove is what we are calling sulcus subtarsalis. Right? Again, we have to remember this, that mainly foreign body can get impacted over there. Okay? And sometimes we may need, of course, we have to evert the lid to remove that foreign body, but apart from that, if you need double eversion of lid, it may not be possible clinically with your hand. In that case, what do we use? This is important and you should know, we go for Desmarais retractor, okay, for double eversion of lid. Okay. So, here we are, a quick revision again, whatever we have drawn, it's written here that palpebral has marginal, tarsal, orbital and sulcus subtarsalis is the area which I just explained it to you, right? Okay. Again, you can see the same parts of the conjunctiva, palpebral here in the diagram. I am very sure you will find mine one more simple and understandable. Anyway, both are good. Then we talk about bulbar conjunctiva. So, bulbar conjunctiva at the limbus is actually fusing with the Tennant's capsule and the episclera, which I just told you are below this bulbar conjunctiva, and they form what you call as rete ridges. So, we understand by making a diagram here that if this is your limbus, let us understand in my way. We are saying that bulbar conjunctiva fuses with the Tennant's capsule and the episclera, and here it forms the rete ridges. Now, these rete ridges, just remember, has got lot of melanocytes, and that is why the area of the limbus is little pigmented, right? Okay. So, this rete ridges, and between this, what is the space? Between the space is what is called palisades of Vogt. Very, very important. I hope you remember. I taught you this when I was teaching you anatomy of the limbus. Palisades of Vogt, this is the area, and what does it contain? It contains the stem cells. What is the role of the stem cells? These stem cells are going to replicate and keep forming the corneal epithelium. So, corneal epithelium regenerates through these stem cells in the palisades of Vogt, right? Okay. Next we have to understand here is there's one exam question I remember. Let's solve this. What is the stem cell marker here? So, stem cell marker would be ABCG2. We will not forget this. This is the stem cell, limbal stem cell marker. So, limbal stem cell marker is ABCG2. Note this question please. Okay, talking about the layers of the conjunctiva, first is of course is epithelium, right? So, epithelium this is exam question, that is non-keratinized stratified squamous epithelium. What is the next layer? Next layer would be adenoid layer, which is a loose connective tissue, and next comes your dense fibrous layer, right? And together this is what is called substantia propria. So, these are the layers of the conjunctiva. Now, we will talk about it one by one. First talking about epithelium. So, if what are the points that we have to learn for the epithelium? Very quickly, the epithelium, of course, one question we have already solved. What very important, it contains the goblet cells. So, the goblet cells are in the epithelial layer of the conjunctiva. This is a very important thing you have to understand. And then there is an exam question where these goblet cells are maximum on what part of the conjunctiva, which quadrant, superior, inferior or lateral or medial. So, we have to answer. It is in nasal or temporal instead of lateral or medial. You can say it is infero-nasal. Okay. So, infero-nasal part, the goblet cells are maximum, right? Okay. What else does the epithelial layer has apart from this? It contains the lymphocytes, and I mentioned about melanocytes, which are present mainly in the rete ridges, right? So, melanocytes. Okay. So, what we were saying is because of that you can get some little pigmentation around the limbus. Let me mention here, do you all remember in uveitis what we learned about? In a Vickers syndrome, there is a sign which is called Segura sign. And what is Segura sign? Segura sign was limbal depigmentation. Okay. So, this is one applied we will keep in mind. This was limbal depigmentation. So, the pigmentation takes place along the rete ridges due to the presence of melanocytes. Coming to stroma, that is adenoid layer. So, next talking about the adenoid layer is mainly loose connective tissue, right? So, this loose connective tissue, what are the things present in the adenoid layer? What are the components here? Of course, we will remember what we find here is majority of the time is a lymphoid tissue, which is the term you have to be familiar with is CALT. What is CALT? CALT is nothing but conjunctiva associated lymphoid tissue. It is conjunctiva associated lymphoid tissue, right? So, when you say, so what are the things here present? We will see lymphocytes and plasma cells. What are the cells? Mainly, note down please, lymphocytes, plasma cells. And of course, this is the layer where you get the blood vessel and the lymphatics. Blood vessels, so number 1, the CALT tissue, number 2, blood vessels, and of course, the lymphatics. So, conjunctiva is one tissue in the eye where you have a lymphatic supply, a lymphatic system. We have to remember that. Okay? Okay. Then we talk about what is next. Next we talk about is fibrous layer. Okay. Talking about the fibrous layer is mainly is a dense connective tissue as we just learned, and therefore, it mainly has collagen fibers and elastic fibers. Right? Now, there is one very important applied here. Let's understand. So, collagen and fibers, okay. Then there is elastic fibers, blood vessels, and very important nerves. So, what is applied here? That nerves are deeply placed inside in the fibrous layer of the conjunctiva. So, this is the reason. The applied here is, this is the reason in conjunctivitis, all of you have experienced conjunctivitis. You may get discomfort, pricky sensation and so on, but not any pain. Okay. So, pain is mainly rare here. Why? Because the nerves are deeply placed. We will note this down. Okay. So, that is why pain is less. So, you will learn that pain is less. No, pain is in normal conjunctivitis, pain is not a feature. Only in a very severe case or slowly when there is a corneal involvement, you can get a lot of pain. Okay. Okay. Then we talk about is the lymphatic system that we were talking about. What are the main nodes where it is draining? So the medial part will be, so when looking at this different nodes, the medial part is going to drain in submandibular and lateral, of course lateral, preauricular and medial submandibular, right. So this you will keep in mind. Coming to a little bit about blood supply. So when you talk about the blood supply, it can be either bulbar conjunctiva or palpebral conjunctiva. What is the blood supply? For bulbar conjunctiva, we are just going to learn it is mainly anterior ciliary arteries, okay, anterior ciliary arteries, and this anterior ciliary artery will be giving the branches, that is your anterior conjunctival artery and posterior conjunctival. These are the smaller branches to anterior and posterior part of the bulbar conjunctival arteries. You just know the name, the details have never been asked in all these last 25 years of your exam, but yes, this much you have to know. Okay, we come to the palpebral and fornix part. Just remember the two names, marginal and peripheral tarsal arcades. These are mainly formed by medial and lateral palpebral arteries, which are a branch of lacrimal. Just know it, names, that is enough. So this is what is anterior ciliary, which is mainly supplying your bulbar conjunctiva. Okay, so you can see this posterior conjunctival artery and anterior conjunctival artery. So this is the long posterior ciliary which I was teaching you, which is a branch of ophthalmic. So long posterior ciliary will supply the base of the iris. This is what it is showing. And these, of course, the two arcades, marginal tarsal arcade is this one and peripheral tarsal arcade is this one. These are the two arcades you have to know. Okay. So that was about the blood supply, and that was all about brief about the anatomy of the conjunctiva. Okay, so next we talk about what is conjunctivitis. Conjunctivitis means inflammation of conjunctiva. So once we know that it is inflammation of conjunctiva, how will the patient present? Of course, the 5 fingers which I taught you all the time, there will be redness, okay, there will be photophobia and blepharo. What is photophobia? What did you learn? That is intolerance to even the normal light. Then blepharospasm. What is blepharospasm? That is your closing of the lids, that is blepharospasm, discharge, and of course, in very severe cases on corneal involvement, we can mention pain if severe. Okay, even your blepharospasm and photophobia and intolerance is more if there is a corneal involvement, but yes, you can get that, right? Okay, then we talk about, once we know this, what are the types of redness? So types of redness. So redness is of mainly two types. One is your ciliary congestion and one is what? Conjunctival congestion. Let's understand what is the difference. So let's have a look here. So these, can you see, these are mainly the straight vessels here which are along the limbus, isn't it? They are draining from the limbus to the fornix. These are this is what is called ciliary congestion. This is what is ciliary congestion, right? This is your ciliary congestion, and coming to what are these? Can you see these are branched, right? And this one is what is called conjunctival congestion. So this is your conjunctival congestion. So what are the differences that you see? These are straight blood vessels, these are mainly branched like this, right? These are branched. This is conjunctival. These are more along the limbus, these are away from the limbus, right? So what is the clinical difference that I should have in mind? That when there is only conjunctivitis, you will have only conjunctival congestion. That means this one, right? So in conjunctivitis, any type of conjunctivitis or conjunctival pathology, we generally have only conjunctival congestion. But when we are talking about serious pathologies like keratitis, uveitis, glaucoma, then along with conjunctival, we will get this ciliary congestion. Okay. Next, talking about the discharge. So when you talk about the discharge, how we learn the different types of discharge, let's learn in my way. Write down, we will learn it like this, BCVA. What is BCVA? Do you all know this? This is mainly short form for best corrected visual acuity. What is the visual acuity after the best correction of specs? That is what is BCVA. I have used this just to learn this way. What are the different types of conjunctivitis? Bacterial, chlamydial, viral, allergic. Main, these are the broad headings. So discharge, if we learn like this, in bacterial, think yourself, bacterial will have either purulent, It can be severely purulent discharge. Where do you get a severely purulent discharge, all of you? Severely purulent discharge you get mainly in the gonorrheal conjunctivitis. Remember that. Then secondly, it could be moderately purulent or it could be mucopurulent. When you talk about chlamydial, it is always mucopurulent. Easy to learn now. This is always mucopurulent. Viral and allergic, we all know it's not difficult. It is watery discharge, right? Viral and allergic, we will say we get watery discharge. So that is the different types of discharge. Let's have a look here. So if you see here, this is again a severely purulent discharge. Okay. One more question while we are talking about severely purulent discharge. They have asked you, especially when you're going to learn ophthalmia neonatorum with me, what is the most dangerous infection in children for conjunctivitis? You should always answer, it is gonorrheal. So, most dangerous conjunctivitis is gonorrhea. Why? Because this can, in children, especially in small children, in ophthalmia neonatorum, this is the most dangerous, is gonococcal conjunctivitis, as it can involve the cornea, right? Yeah. Okay. Right. So, here again you are seeing this is your conjunctival. I think now it is very, very clear to you all that this is your conjunctival congestion. Here you are seeing it on the palpebral conjunctiva and this one is on the bulbar conjunctiva. So, when there is conjunctivitis, we have just learned how the patient presents. So, what are the different signs? Of course, one is discharge we have talked about, redness we have talked about. What else you can get? Let's see that. Okay. So, next what you can get is chemosis. Can you see this? Chemosis is nothing but edema of the conjunctiva. So, edema of conjunctiva is called chemosis. Right. So, here you have congestion with chemosis. Then what you can get is follicles. Can you see that? In this case, it is showing you this sago grain like follicles which are mainly on the upper lid. If it is on the upper lid, sago grain like, what are we talking about, all of you? We are talking about trachoma. This is the, so what are follicles, all of you? Follicles are nothing but aggregation of lymphoid cells. Okay, and here you can see the follicles on the lower palpebral conjunctiva. So, lower lid or lower palpebral conjunctiva, you can see this. This is mainly a feature of viral conjunctivitis. Okay, so this is mainly a feature of viral conjunctivitis. This is follicular conjunctivitis. Talking about follicles here, so we have just learned that this is aggregation of lymphoid cells, isn't it? Yeah. So, this is aggregation of lymphoid cells. Little more here, follicles are maximum in the fornix. Another important point, follicles, we are talking about follicles here. So, note down, follicles are maximum in fornix. Which layer will you will see the aggregation of lymphoid cells? Calt is present where? Adenoid layer. Now, what happens? This adenoid layer is not formed in a newborn child. It forms only after 2 to 3 months. Therefore, we have to learn this. This is the clinical applied part that you should know, that there are no follicles formed in neonate. Okay, newborn child, you don't get follicles. Why? Because adenoid layer, please note down, is formed after 2 to 3 months. Okay, is formed after 2 to 3 months of birth. Right? And of course, lymphoid and aggregation of lymphoid tissue, it is mainly in the adenoid layer. Right? And what is this? Which is this sign? We are just talking about on examination and signs that you can see in conjunctivitis. So, can you see these areas are not round, or though they are elevated, but they are not roundish like in this case where you could see the follicles. This is more elevated and round, but this one is flat, right? So, these flat raised areas, this is what is called papilla. Okay. So, this is a papilla or papillary reaction. So, we can learn like this, that pathologically whenever there is any conjunctivitis, there are two types of reactions. Okay. So, if I talk about pathologically, so let us learn here that pathologically when there is a conjunctivitis, there are two types of reaction. One is follicular reaction, which we just learnt, and another is your papillary reaction. Now, when you say papillary reaction, it is just as we saw, there is formation of papilla which are raised flat area. So, what is a papilla? Let's understand. So, what is this papilla? So, these papilla are nothing but mainly epithelial layer hyperplasia. Okay. So, epithelial hyperplasia. When you look at a papilla, you see epithelial hyperplasia plus, very important, there is a central blood vessel. Then only it is a papilla. And of course, some lymphocytic infiltrations, that is immune cells are present, right? Lymphocytic infiltration. Okay, so that becomes your papilla. So, lymphocytic infiltration, when I say, these can be lymphoid cells, lymphocytes or plasma cells. Now, what is a giant papilla? Where do you learn giant papilla? In contact lens, soft contact lens wearers, they can become intolerant. When they become intolerant, that can lead to giant papillary conjunctivitis. So, giant papilla is the term used when this is more than 1 millimeter. When the size is more than 1 millimeter, this is called giant papilla. Okay? So, this was about your papillary and follicular reaction. What is the next sign that you can get is subconjunctival hemorrhage. Why? In case of hemorrhagic conjunctivitis, you can get this subconjunctival hemorrhages. Next, of course, this is what? It's a pseudomembrane formed over the eye, covering even the cornea here. This typical look of a pseudomembrane is what we call as ligneous conjunctivitis. Okay, we'll write it later. Just have a look. This is your pseudomembrane. What is the pseudomembrane and what is the true membrane? Pseudomembrane, it will not bleed on peeling. Please, no confusions. This is absolutely non-debatable. Okay, pseudomembrane, it will not bleed on peeling, whereas membrane, it bleeds on peeling. Okay. Then talking about the treatment. I hope you understand. Again, we can go back to the treatment part, and that is BCVA again. When you say BCVA, bacterial, of course, I will give antibiotic eye drops. Right? Generally, we start with any broad spectrum and it responds. Not, then we have to be more specific with things, but generally it responds, right? Okay, then we talk about chlamydial. Let's make life simple. This also needs antibiotic eye drops. Okay, what about viral? This also needs antibiotic eye drops. Please write the way I am writing for you. This way you are going to retain things better. I hope everybody knows about the picture memory. Okay, so this is what viral means again. Why? Because we don't give antivirals. It is going to go off by its own. It will anyway not be, only antivirals are required if it is herpes simplex infection, then you can start with acyclovir. Otherwise, we only give why are we giving antibiotics? Antibiotics are given to prevent secondary infection. To prevent secondary infection. So, antibiotics are given to prevent secondary infection. And of course, A for allergic. And allergic, of course, what we will write here, we give anti-allergics and steroids. So, we give anti-allergics and steroids are particularly chosen, the mild ones, of course. You know why? Because steroids can lead to cataract and glaucoma. Okay. Once we know all this basic, we come one by one. First heading, give acute bacterial conjunctivitis, right? Common? Okay. So, when you say give the heading acute bacterial conjunctivitis, see, everything is there, the signs and symptoms, we don't have to repeat it again and again. I have told once for all. So, we can just write down here, okay, the same signs and symptoms here. But what is very important then, what is going to be asked is etiology also is there is a question here. What is the most common cause? Most common, of course, is always answered as Staph aureus. What are the other causes, etiology, apart from this Staph aureus? We will answer Streptococcus pneumoniae. Next common can be, of course, there is no sequence. Now, we are just writing the etiologies. Streptococcus pneumoniae. And third, of course, in children, you should know Haemophilus influenzae. Okay, in children, we will know in Haemophilus influenzae. Okay, one more thing I would like to add in the treatment part, which we missed. Of course, treatment, we are giving all these in topical. But if this patient is having a gonococcal infection and there is a risk of systemic infection, you want to note down? Note down. In case of gonococcal infection, you may have to go for third generation cephalosporins. Okay, so we may have to give a systemic treatment. Okay. So we know what is the, if you know the etiology, clinical features, whatever we have learned can happen. And of course, treatment will be antibiotic, eye drops. This is also learnt. Nothing much to write here. Only thing is remember the etiology. Okay. What are the investigations we should know? Of course, microbiological staining. Gram stain, Giemsa stain, we all know that, right? Of course, PCR is most accurate. Just know the headings. Immunofluorescence microscopy may be helpful, and very rarely we may have to go for a biopsy. Generally, absolutely not needed, but very rarely, yes, anything is possible, right? So, these are the basic headings. Just have an idea. In any conjunctivitis, we can go for these investigations. Mainly, it is the microbiological which is going to help you. If not, then PCR is of course very, very helpful, right? And of course, treatment would be same as explained. That was about acute bacterial. We come to the next heading. Next heading is pseudomembranous conjunctivitis. What is a pseudomembrane? It is nothing but exudates which are formed on the inflamed epithelium, right? So, when you are going to peel it, it does not bleed on peeling. We will not forget this. So, how do you learn? Learn in my style. What is pseudomembranous conjunctivitis? Just say all the features, all the 5 features, all the features that we have learnt about conjunctivitis. Along with that, there is a pseudomembrane formation. This is called pseudomembranous conjunctivitis. Pseudomembrane formation. Right? This is pseudomembranous. They will ask you next is what has to be remembered is the etiology. So, when you are learning the etiology of pseudomembrane conjunctivitis, very important, first is your, we can divide as bacterial, viral or chemical irritants. Now, we have to remember this is ours, that first we should always know that diphtheria, which causes membranous conjunctivitis, a mild diphtherial infections can lead to pseudomembrane. Okay? Because this has been in the MCQs and many people said, no, diphtheria to membranous is causing membranous, it's not causing pseudomembrane. It's not the case. Mild diphtheria will cause pseudomembranous conjunctivitis. Okay? So, mild diphtheria, very important, which bacteria? Streptococcus hemolyticus. These two you have to remember. Then of course, Staph aureus and gonococcus, but the numbered ones are very important. We come to the next is viral causes. Viral causes very important is severe adenoviral infection. Okay, this is again very important, severe adenoviral, or it can be herpes simplex. And of course, we can't forget chemical irritants. So these are the main causes. Have you learned with me? Very important, mild diphtheria, Streptococcus hemolyticus, severe adenoviral infections, chemical irritants. Of course, we add Staph aureus and gonococcus for the bacterial and herpes simplex for viral. Now, is it okay? So, these are the causes. We already know what is pseudomembranous and we have to treat according to the cause. Generally, we will give these antibiotics. What was this one? You explain this. This is again a typical pseudomembrane, which is, I told you earlier also, this condition is called ligneous conjunctivitis. Again, this is going to peel very easily. Okay. So, this ligneous conjunctivitis is mainly a feature of, mainly it's a genetic condition. Okay. So, this is a genetic condition where the patient has pseudomembranes in the different parts of his body. Okay. So, just remember this. Okay. We come to next is membranous conjunctivitis. Again, learn in my style all the features with membrane formation. And what is a membrane? True membrane? Membrane formation, which is, yes, it bleeds on peeling. This time it bleeds on peeling. Right? So, this is your membranous conjunctivitis, which will bleed on peeling. Of course, the cause I have just mentioned is Corynebacterium diphtheria. What is the treatment? Anti-diphtheria serum is given. Done? Okay, we come to the next. Angular conjunctivitis. Angle. What is angle? We are talking about medial and lateral canthus. So, what is angular conjunctivitis? Conjunctivitis are the two canthi with excoriation of skin. So, even the skin, have a look here, this is the excoriation of the skin which happens. So, conjunctivitis are the two canthi with excoriation of skin. This is your angular conjunctivitis. Moraxilla, main cause is moraxilla, and second is Staph aureus. So, etiology is again important. They can ask you Moraxilla Exenfeld. This is mainly asked, and of course, you should know about this is lacunata, C-U-N-A-T-A. Please make this correction. It is lacunata or Moraxilla catarrhalis. These are the three moraxillas, and of course, Staph aureus. Okay? Moraxilla is a diplobacilli. So, again you are going to give treatment as antibiotics in both the cases, and of course, one more important thing is zinc oxide lotion. Why you give zinc oxide lotion? Because it inhibits, this is for the excoriation of the skin, it inhibits the proteolytic enzymes. These are, so this one is a Q, they have asked you about zinc oxide, they have asked you about Moraxilla Exenfeld. I think once there was lacunata was also mentioned, but these are the two questions. Done? And of course, membranous is caused by, this is also has been asked in the exam. How will you learn? Again learn like this, all the features with subconjunctival hemorrhage. That's it. Again in my, all the features with subconjunctival hemorrhages, hemorrhagic conjunctivitis. So, these are the subconjunctival hemorrhages that you are looking at, right? Okay, so etiology we are going to divide it into bacterial and viral. Bacterial causes, pneumococcus, very important, this was asked, and Haemophilus, pneumococcus and Haemophilus. Coming to the viral causes may enterovirus 70 should be always preferred if suppose there was a question, almost all these 4 viruses were given, right. So, if more than 2 options are correct, which one to choose? So, enterovirus 70 comes always first because there was a very severe epidemic of enterovirus 70. Since then it is asked, but I am not very sure it is going to be asked now. It has been a long while now, but still you should know this, right. So, this was a Q. Enterovirus 70 we will prefer always first. Next is your adenovirus, then Coxsackie 24 and Ecovirus 34. Okay, so that was the etiology. Of course, if it's viral, we can't do much, and talking about bacterial, you know what you have to do. We come to another important thing is subconjunctival hemorrhages. So, what are the main causes of subconjunctival hemorrhage apart from your viral conjunctivitis? So, apart from this hemorrhagic conjunctivitis, I mean to say, so apart from the bacterial or hemorrhagic conjunctivitis, what are the other causes of subconjunctival hemorrhage? This is again important. We will make a Q here. Trauma. So, if a patient is coming to me, I know this is not a case of conjunctivitis, there is a hemorrhage here, I will first ask whether you got any trauma, any foreign body, have you really rubbed your eyes, right. So, trauma is one next important cause, and the third, if he says no, I didn't, there is no history of trauma, I am going to ask for monitoring of the blood pressure morning, afternoon, evening, at least for a week or 10 days, because the next important cause is hypertension. What are the other causes? The BT-CT can be raised, bleeding time, clotting time, that is your bleeding diastasis. Of course, foreign body, I told you, foreign body, not sensation, foreign body itself can be cause of little bit of subconjunctival hemorrhage, and same for contact lens, and very important, whooping cough, that is pertussis or whooping cough, right. So, that was about hemorrhagic. We next talk about is a very important topic, and that is trachoma. What is trachoma? Trachoma is a conjunctivitis which is caused by Chlamydia trachomatis. What are the serotypes? A, B, B, A and C. Okay? It is mainly a disease, mainly seen in children. What is the age group? It is 1 to 9 years of age. And very important, this is the leading cause of irreversible and preventable blindness. Very important. And I think now it has been eradicated from India, is a very recent news that trachoma has been eradicated, not even a month. We just saw that this news is that the trachoma is eradicated from India. I hope so, right? Okay, so this is about what is trachoma. Now, before I move further into the clinical features of trachoma, very quickly let us revise a little bit. Chlamydia trachomatis is causing 2 types of infections. What are the 2 types of infections? So, chlamydia trachomatis we can learn like this, that one is your TRIC, this is your trachoma inclusion conjunctivitis. This agents, these are one type TRIC agents, and this is mainly causing inclusion conjunctivitis. The one which is happening in the children, we are calling it trachoma. We just learnt just now. And the one which is happening in the adult is called adult inclusion conjunctivitis. Now, adult inclusion conjunctivitis is also called, this is your exam question, it is also called, of course, which serotype? First, let us learn the serotype. Which serotype? It is D2K. This is again a Q. Trachoma with serotype A, B, B, and C we just learnt. This is also a Q. And then we have to learn another Q here, that this is also called swimming pool conjunctivitis. And swimming pool conjunctivitis is, all of you, also caused by another cause of swimming pool. This term is used in two conditions. One is D2K infection, second is adenoviral infections. Okay, we will remember this please, adenoviral infections. Then also we say this is another cause of swimming pool conjunctivitis. Okay, because it is mainly through the swimming pool, when the people using common swimming pool and they are getting infected because of the genital infections. We come to the next is, of course, we know lymphogranuloma venereum. It's a common mistake to confuse, that's why I am mentioning all this here. So, this lymphogranuloma venereum which is caused is by which serotype? Lymphogranuloma venereum, that is L1, L2 and L3, right. And we know here, of course, we can get severe conjunctivitis, fever, preauricular lymphadenopathy, right. You should know this. And preauricular lymphadenopathy, lymph nodes are enlarged. Next we talk about is, how will the patient present? So, clinical features, now again in my style, IW, lot of itching, lot of watering. So, the patient is presenting with lot of itching and lot of watering. This is the main problem, lot of itching, uncontrollable. Okay. So, this is how the patient is presenting. And of course, when you say watering, it is not only watering, we have to mention here what was the type of discharge, it is mucopurulent discharge. Okay. So, what we get here is a mucopurulent discharge. Okay. Coming to on examination. On examination, we will first understand and learn that this trachoma is divided into two stages, active stage and chronic psychiatrical stage. So, in active stage, when there is itching and watering, what are the findings in the patient? And when there is a scarring, what are the findings in the patient? Let's learn. So, when you say the active stage, we'll make a diagram, of course, we always learn like this. What are you getting in the patient? We get, just now we learned, sago green-like follicles, okay, in the upper palpebral conjunctiva. All of you make the diagram, sago green-like follicles in the upper palpebral conjunctiva. We get the same follicles, some follicles at the upper limbus, and the ones at the upper limbus are called Herbert follicles. This is what is Herbert follicles. What else you can get? We can get some corneal epithelial defects. In an active stage, we may get, if the cornea is involved, corneal epithelial defects. And slowly, of course, there is another important thing that you have to know is neovascularization of the cornea, which we call as pannus, right. So, pannus may be formed. So, this is how you will draw and learn it once for all. So, can you see this is the neovascularization. Okay, next, before I go to this scarring stage, so one more important point in pathology that you have to know is that trachoma, give the heading pathology, is one conjunctivitis where there is both follicular and papillary reaction. So, both follicular and papillary reaction, and this is exam question, this has been asked in the exam. So, along with the follicles, let us also draw some papilla here. we can also get the papilla formula. We have talked about what is papilla and what is follicle. Okay, so this is your active stage. So here we are, you are looking at pannus. What is pannus? It is mainly neovascularization, but along with the blood vessel, we will remember there is also lymphocytic infiltration or proliferation. Okay, lymphocytic infiltration. Along with the blood vessels, we have lymphocytic infiltration. Okay, so this is what you are looking at is pannus. Now, what is progressive and regressive pannus? When the lymphocytic infiltration is seen at the head, it is called progressive. But if you do not see, so you can get neovascularization without the lymphocytic infiltration, then that is called regressive pannus. Okay, so without lymphocytic infiltration, and here when it is in this case, just at the tip you can see lot of lymphocytes which are present, right? Okay, so that was about one thing about active stage. Next we talk about is chronic stage. When you say chronic stage, what are the on examination? Again, let's draw the diagram here. So in chronic stage, what is happening? Initially there was follicles. This is what we learned, right? You remember? So follicles were on the upper palpebral and they were on the upper limbus. Later on what happens? There is scarring, and this scarring is seen in form of a line. This is what is called, again it is a repeated question of your exam, let us note it down. This is what is Art's line, okay. This is what is called Art's line. And at the limbus, what were you seeing? We were seeing Herbert follicles. Now when there is scarring here, you see this type of cycratization can lead to pits type of thing which is called Herbert pits. See, I have made another cube. This is also exam question. So, Herbert pits. Okay, we may get some neovascularization and pannus also seen on the chronic stage, of course. And then what else? When there is a scarring, it is not only Art's line. When you are talking about scarring, this is going to also cause misdirection of eyelash. It is in the palpebral conjunctiva, Art's line. Okay, so when there is a misdirection, what is that called? We call it, when the misdirection of eyelash is what is called trichiasis. And if there is misdirection, common sense, it can rub on the cornea. And when it rubs on the cornea, it will lead to corneal ulcer and corneal opacity, right? So, another thing that can happen apart from trichiasis, inward rotation of the lid margin. Inward turning of lid margin is what is called entropion. So, here what you are getting is psychiatrical entropion, right? Okay. So, these are the findings, and of course, this can lead to later on any ulcer can finally lead to corneal opacity. So, they have asked you one question, what is the complication of trachoma? All these are sequelae, trichiasis, entropion, we learn it as sequelae. Complication is only one, okay. So, make a Q and learn, complication is only one, and that is corneal opacity due to corneal ulcer, formation of corneal opacity. This is the only complication. Okay, important question. So, let us have a look. This is what are, these are the Herbert pits, right? Is it clear? On the limbus, upper limbus. This is your Art's line. So, we have talked about one important point here in pathology. Let us give again the heading pathology. One more thing I want to add here. One thing that you learnt was that both are exam questions. So, first let me make a Q here. These are both exam questions. First point we have already done, and that is that this is a conjunctivitis where there is both follicular and papillary reaction. Ye to theek hai? Fourth, follicular and papillary reaction. And second very important thing is your HP bodies. Sometimes they ask you this question also. What are HP bodies? HP stands for Halberstadter Provezak. Halberstadter Provezak. Just know this, these are intracytoplasmic inclusion bodies. Okay, these are intracytoplasmic inclusion bodies. So, this term is mainly related to HP bodies is nothing but intracytoplasmic inclusion bodies. So, that was about pathology. One more point here. Okay, so talking about investigations first. So, investigations, of course, what are the things that we can do? One is your PCR, right? Generally, again, not needed because diagnosis is majority of the times clinical. But yes, if you have to go for it, which is the cell culture, you should know it is McCoy cell culture in case of chlamydia infections. And GIMSA staining is mainly for this HP bodies. Okay, the GIMSA staining is mainly for HP bodies. So, these are the investigations that we can go for. Coming to treatment. So, everybody knows what is safe strategy. It's a repeated question in all the exams, even recently asked. So, safe strategy, please know, is a WHO program to control trachoma in any area. Okay? So, what does it stand for? So, the safe strategy is nothing but a WHO program to control trachoma. To control trachoma, just be alert here. Okay? So, when you say to control trachoma, what are the safe, what are the measures, what is S, what is A, what is F and what is E? I think you all know this. Stands for surgery, antibiotics, facial hygiene, environmental cleanliness. So, once we know this, the next thing that they are going to ask is which surgery. So, the sequelae has to be managed, trichiasis and entropion, by doing a bilamellar tarsal rotation. Then which antibiotics? Antibiotics that you have to know is either you can go for oral azithromycin or we can go for topical tetracycline. Topical tetracycline. Topical tetracycline is given only in an ointment form. This is the drug only in ointment form. Which is the other drug which is only available in ointment form? Acyclovir. So, this is around 1% ointment is available for tetracycline. And what is the dose of azithromycin? We all know it is 20 milligrams per kg for children, and in adults, we will just say for adults it is 1 gram. We all know this, right? Okay. Which is better? Which I should choose? Of course, azithromycin. Why? Because tetracycline number 1 is considered a little less effective than azithro. Secondly, it's an ointment. It's very difficult to maintain the compliance. It's so cumbersome to keep putting ointment in the eye and moving around. Easier to eat 1 or 2 tablets, isn't it? That is why compliance is poor and also it's less effective. And thirdly, of course, tetracycline has its own disadvantages. You all know that, the side effects, just revise it, right? Staining of teeth, impairment of growth and so on. So, that's why we will prefer the drug of choice. So many times they have asked you for treatment, for prevention, it's always azithromycin. If they ask you drug of choice for blanket therapy, again it is azithromycin. In safe strategy and treatment, again it is azithromycin, right? Okay. So, once we are talking about azithromycin, is there any other antibiotics that you can give for the treatment? Yes, you should also know some other options for treating. Apart from azithro, the other options of treating can be through number 1, sulfacetamide eye drops, right, commonly used. Now, sulfacetamide eye drops, you have to know that you have to check for any sulfa allergy in the patient before you choose to give this. Okay. So, sulfacetamide eye drops number 1, or we can go for doxycycline or erythromycin. Erythromycin or doxycycline. Right? Just know the options. Now, okay, so this is a safe strategy, which is a WHO program. There is another interesting question here that, okay, what is the indication that how should I decide that, okay, in this area I am going to start safe strategy, in this area it is not required. So, we are looking at the prevalence of trachoma follicles, that is stage 1. So, when you talk about staging, stage 1 is your prevalence of trachoma follicles. क्या पढ़ा था? Generally, stage 1 is when the trachoma follicles are more than equal to 5 follicles in the upper palpebral conjunctiva. So, if the prevalence of this trachoma follicles is more than 10%, okay, this is when we go for safe strategy. This is the indication to follow the full safe strategy: surgery, antibiotics, facial hygiene, environmental cleanliness. So, this has been your again exam question, that is why we are learning this, but rest of this is not exam question, but we should know it further. that if the prevalence is ranging not more than 10 but between 5 to 10, then we only follow your FE, facial hygiene, environmental cleanliness. Less than 5, nothing is done. What do you mean by that? What we mean by that is under this program, nothing is done. Of course, FNE should always be followed. Okay, but what is important, you shouldn't forget, is more than 10% prevalence of trachoma follicles, then we start the safe strategy. Okay, so talking about WHO classification of trachoma. So, what are the different stages? Stage 1, 2, 3, 4 and 5. We learn it with the mnemonic FISCHO. Okay, so when you say FISCHO, it is follicles. How many follicles? More than equal to, you should also have a sign of equal to 5 follicles where in the upper palpable conjunctiva. This has been asked, How many follicles and where? Then I of course stands for inflammation, that is a lot of itching and watering stage, scarring, arch line, Herbert Spitz. Then it is trichiasis, stage 4. So, this can be called as TF stage, TF. This is TI, trachoma inflammation, TS, scarring, TT, trachoma, trichiasis, and CO is corneal opacity. And we have just learned this, that corneal opacity is the one only complication for trachoma is corneal ulcer followed by corneal opacity. Clear? Okay, so we come to the next heading, and that is, write down ophthalmia neonatorum. What is the other name of ophthalmia neonatorum? We call it neonatal conjunctivitis. Give the heading, all of you. Neonatal conjunctivitis or ophthalmia neonatorum or ophthalmia neonatorum. Okay, how do you define this? So, we all know what is ophthalmia neonatorum. This is any conjunctivitis within less than 1 month of age. Again, it is an important topic asked in your exam. What are the causes and what is the most common cause? And let's see what are the things they ask you. What is the most common cause? Number 1 is always chlamydia. Okay, so main question is on etiology. So, what are the different etiologies of why will a newborn child have conjunctivitis? This is what you have to think with me. So, one important is chlamydia, second is gonorrhea. Let's talk first. And why will that happen? Common sense, through when the child is born through vaginal delivery, and if there has been any infection in the mother, the child gets this conjunctivitis. So, chlamydia and gonorrhea mainly through the vaginal delivery. So, most common is mainly chlamydia. Next thing is time of presentation is asked. So, first of all, we will make a Q and write it here, most common. Time of presentation is the next thing that you should know. It is in weeks. If you talk about chlamydia, it is 1 to 3 weeks. And for gonorrhea, this is make life simple, 1 to 3 days. This is again asked. And yes, I have talked about most dangerous infection is, most dangerous you will answer is gonorrhea. What can be the other causes? Influenza, of course, but mainly remember herpes simplex, which 1 or 2? It has to be 2. It is through the genital infections again that the child is getting conjunctivitis. Otherwise, conjunctivitis is generally by HSV1. But in case of neonatal, it is by HSV2. So, this fact is therefore very important that it is by HSV2. Okay? Then of course, Staphylococcus aureus. And lastly, so apart from the vaginal delivery and infection through the vagina that the child is getting conjunctivitis, is there any other means of generally getting these infections? Yes, the other cause could also be, you should know, nasolacrimal duct obstruction. So, if the child has NLD obstruction, we will learn in the lacrimal drainage system how a non-canalization of NLD can lead to stagnancy and therefore infections can happen, right? Especially Staph aureus and so on. So, then we talk about what is chemical conjunctivitis, which is the next etiology. So, one was chlamydia. What is the second? Gonorrhea. I am repeating so that you learn with me. Herpes simplex, Staph aureus, chemical conjunctivitis. First say chemical, then herpes simplex, Staph aureus, NH influenzae. Why chemical important? Because again exam mein aata hai. So, chemical conjunctivitis is when you have put 1% silver nitrate in the child's eye to prevent. Why do you do this? If the mother has gonorrheal infection, we do it to prevent gonorrheal infection, to prevent a gonococcal conjunctivitis. And this method of prevention is what is called Creed's method, right? This is what is Creed's method. So this is also a Q. What is Creed's method? Do we follow this now? No, sir, because this 1% silver nitrate causes chemical conjunctivitis. And of course, that will definitely manifest very, very quickly, that is within 24 hours. So it manifests within 24 hours. Another important point. Okay. So therefore, क्या पढ़ा हमने? Chemical is when we are using silver nitrate 1% in the child's eye to prevent gonorrheal infection, he can get chemical conjunctivitis. This method of prevention is called Creed's method. Then they have even asked you like this, do we follow Creed's now? No, we don't. Why? Because of this problem. So what can you do to prevent this infection, gonococcal infection, or for any prevention of the infection, what we can do? Let's see. Number one, we can go for, apart from silver nitrate, we can go for povidone iodine. We can also use erythromycin eye ointment, okay, or we can just clean it with or put povidone iodine into the eye, right? We all do that, and whenever we are part preparing before any surgery, we use povidone iodine. And there has been a question that which is the best method to prevent any infection. Is it pre-operative antibiotics? Is it per-operative, post-operative? It is always part preparation, which is always the most important part of the whole thing to prevent any infection, right? This was the question? Yeah. We'll also add here that apart from povidone iodine and erythromycin, another important thing that can, if needed, we can go for single IM dose of benzyl penicillin, okay? And IM dose of benzyl penicillin to prevent gonorrheal infections. This is also one of the modalities if needed, right? Especially if we are suspecting gonorrhea. Other infections you can do, and you can just choose any of the three, but preferably we are not choosing silver nitrate now. We are not preferring silver nitrate now. Okay, so that was prophylaxis. Have a look at the case. So this is a child with infection which is ophthalmia neonatora. Okay. Okay, one more thing that we would like to add here when you're talking about preventing the infection, and of course, if it happens, you have to treat accordingly. If it is a simplex, if you are actually suspecting HSV2 infection, right, then we have to know that the systemic involvement, risk of systemic involvement is very high. So your treatment has to be very much vigorous. Okay. So then we have to treat with that vigor. We have to even go for PCR for a confirmation. We have to check if it's not causing encephalitis. So we have to check the CSF to exclude an encephalitis. So this is one point. Again, at your level, it may not be asked. This is one little extra point that you have to know, right? For any simplex, of course, we know what treatment we are giving. It's mainly acyclovir, right? Our details we have discussed in the cornea chapter. So that was ophthalmia neonatorum. We next talk about is viral conjunctivitis. Okay, so let's give the heading viral conjunctivitis. So when you say viral, what comes in your mind? We have already done all the homework before starting with different conjunctivitis, right? So again, all the features, what type of discharge? Watery discharge. What is the treatment you give? We don't need antivirals except for herpes. We generally go for antibiotics to prevent secondary infection. This much we have learnt, right? Okay, and if you remember few more points that I discussed with you, that follicular, it is mainly a follicular reaction and it is involving the lower palpebral conjunctiva. Anything else? Yes, we have also talked about that sometimes some viral infections can lead to hemorrhagic conjunctivitis. Okay, so we come to, this was a quick thing, we will come to viral conjunctivitis. Again, clinical features are the same, 5 as we know. Right? It is more contagious, we all know that, we have this idea, right? And it is mainly the watery discharge which is important, and follicular reaction, again very important point, mainly involving the lower lid, mainly involving the lower palpebral conjunctiva. It is the lower palpebral conjunctiva. Right. Okay, so let's next what you have to learn is your etiology. Next is etiology. If you look at the different causes of conjunctivitis, let us understand that adenovirus is the 90% viral conjunctivitis is adenovirus. Okay, 90%. Okay, when you talk about adenovirus, what are the different types of adenoviral conjunctivitis? It can be a simple follicular, number one, or it could be pharyngoconjunctival fever, right? So, when you say pharyngoconjunctival, it is occurring by the serotypes 3, 4 and 7, and this one is which is called swimming pool conjunctivitis. That is pharyngoconjunctival fever. This one is the term used for a swimming pool conjunctivitis. ठीक है, 3, 4 and 7. दूसरा क्या है? Epidemic keratoconjunctivitis. The epidemic keratoconjunctivitis is what? This is most commonly by strain 8. और ये टेढ़ी चीज़ है. Just like 8, it is more severe. Just remember this way. And 80% of this will lead to another 8, easy to learn, will lead to nummular conjunctiva, keratitis. We have learned nummular, if you remember, in the cornea, how there are circular lesions involving the stroma. This is your nummular keratitis, right? So, mainly most common, most severe both is serotype 8, twisted, right? Okay. Then lastly, of course, hemorrhagic conjunctivitis. We all know severe adenoviral infections can lead to hemorrhagic conjunctivitis. That was adenovirus. What is the next cause? Next cause can be COVID, of course, very, very important. It leads to acute. Most common ocular feature or ocular manifestation of COVID-19 is acute follicular conjunctivitis. What is the other thing the COVID is causing in the eye? You should remember this. The serious one is central retinal artery occlusion, isn't it? We have learned this. So, it can lead to central retinal artery occlusion. Okay. The next we talk about is, of course, the next cause can be a simplex infection which is leading to this, and systemic disease in the viral illnesses. Even this can lead to associated conjunctivitis. And lastly, molluscum contagiosum, which is caused by pox virus. These are the causes of viral conjunctivitis. Now, one question which I remember here, we will learn this. What is the most common ocular manifestation for measles? Of course, I am talking about ocular manifestation. You should answer vitamin A deficiency. Agreed? Another question. Most common ocular manifestation of mumps. So, if this is ours, most common ocular manifestation for mumps. What will you answer now? Now, we will answer it is dacryocystoadenine. Dacryo is lacrimal, cysto is sac, adenitis is gland. So, dacryocystoadenitis. Matlab, both sac and gland are inflamed. I haven't written dacryo fully, but you should write. So, it is dacryocystoadenitis. Both sac and the glands are inflamed. This is for most common ocular feature of mumps, and most common ocular feature of measles is vitamin A deficiency. Right? So, this was etiology. What next? Clinical features. I have discussed it in the beginning itself. We will get all the features. I just write this as all the features. We have to remember there can be watery discharge, subconjunctival hemorrhages, and of course, let us not forget preauricular lymphadenopathy. So, this is a case of viral conjunctivitis with a watery discharge. It's a very contagious thing, and very soon the other eye is definitely going to be involved, right? And here you see the follicles. On examination, you can give a heading and write down. It's a follicular reaction on the lower palpebral conjunctiva, right? And of course, the preauricular lymphadenopathy is the another finding. Okay, so what is molluscum contagiosum? So, we will learn it as an umbilicated nodule on the lid margin, okay? So, this is described as umbilicated nodule on lid margin. And what is the treatment here? We generally excise. So, treatment is excision. Okay? That was about your viral conjunctivitis. We come to the next heading, and that is allergic conjunctivitis. So, talking about allergic conjunctivitis, right? So, what was the basic things that we had already discussed? Allergic again is a watery discharge, just like viral. And of course, for the treatment, we start with anti-allergics, and if it is not agreeing with it, not responding to it, we go for mild steroids. So, this much we know, and I think we all have got this idea. Allergy means a lot of itching, and watering will be the presentation, right? Okay. Do you want to note it down? If yes, please note it down that when you talk about allergic conjunctivitis, this is our next heading. Allergic conjunctivitis, mainly the clinical features would be all the five things, again the same. Only thing is it is a watery discharge, and of course, we know it's a conjunctivitis, so it is conjunctival congestion. Okay, can we move further? Okay, we talk about specific types of allergies. So there are three main headings that we are going to cover. So what are the three main headings? That is flectanular, vernal keratoconjunctivitis, atopic keratoconjunctivitis. We start with flectanular. When you say flectanular keratoconjunctivitis, flectin means what? A nodule, right? So we start with flectanular keratoconjunctivitis. So talking about flectanular, flectin means a small nodule near the limbus, right? So the first important thing is why it is happening. What is this allergy? This is important, as in the exam we will learn. This is allergy towards endogenous antigen. What do you mean by endogenous? There was some infection in the body and in response to that there is an allergy. Which endogenous? Which endogenous? The first answer would be Staph aureus. Okay, so we will not make this mistake to first answer TB. TB or tuberculosis will be the second option. Our first option becomes Staph aureus. This is one important point now, right? So it is due to endogenous allergy, number one. Okay, what are the clinical features? We have already said. So clinical features, again IW, itching and watering. This is how this patient will present. When I examine the patient, what do we see? This is important. Look here. So this is the nodule of flectin near the limbus. You can see that. And of course, conjunctival congestion. So I can see this flectin and I can see conjunctival congestion. This is generally the on-examination finding. So let's draw a diagram here. On examination. Initially, there is a flectin and there is conjunctival congestion as we have just seen, right? Let's mark this as flectin. Later on, what happens? Slowly it is a keratoconjunctivitis. It is going to involve the cornea. And if it involves the cornea, this is next exam question, this is going to lead to fascicular ulcer. It leads to fascicular ulcer. Make a Q here. And this fascicular ulcer can later extend as ring ulcer. This fascicular will later extend as ring ulcer. Right? This is important. Another question. So, one question was endogenous allergen, second fascicular ulcer. Now, I am telling you the third question. Third question is about which hypersensitivity reaction is this? We answer it's a type 4 hypersensitivity reaction. It's a type 4 hypersensitivity reaction. Right? Okay. So, next, if that is so, what will be the main aim of the treatment? We have to give steroids, right? So, the treatment here would be steroids, topical steroids. Another important point, if it is due to staphylococcal infection, sometimes that can be associated blepharitis and that can be the cause of recurrent problem, right? So, generally we have to see if the patient is presenting with this recurrent problem, it is becoming recurrent, go and check for if there is associated blepharitis or not. Actually, we don't need to do that. Once the patient is there and sitting on the slit lamp, we see everything outside to in. Kitni der lagti hai na? So, if there is any associated, you have to note this down here. If associated blepharitis, okay, then what is happening? This is staphylococcal blepharitis. It's better to treat this as well. We start with oral tetracycline or doxycycline. So, that doesn't occur again and again, right? Okay, that was flectanular. These were the questions. We come to the next one and that is vernal keratoconjunctivitis. What is the other name of vernal? We also call it spring catarrh. Spring catarrh. Does it happen in spring? No. Spring Apart from spring, it's mainly a disease of summers. So you can consider it as a misnomer. Okay, so there are two misnomers in ophthalmology. One is this one, and second one is what? Retinoscopy, which is not used to see the retina, but it is mainly to assess the refractive status of the patient. Right? Okay, so this is a disease of summers we just learnt, number 1 point. Second important, it is mainly the age group involved is male children. And this time it is allergy towards exogenous allergens, that is dust and pollen. Okay? Another important point I would like to add here only is this is one conjunctivitis where there is no follicular reaction, it's only papillary. This has been your important exam question, please. Okay? So, no follicular reaction. So, how is your patient going to present? The same, itching and watering, lot of itching, lot of watering, and very, very important apart from this is ropey discharge. This is your next question. Okay? So, the patient presents with ropey discharge. What is ropey discharge? These mucoid discharge when it is coming between the, so you know there is a papillary reaction. In the palpebral conjunctiva, these raised papilla, so when the mucus is passing through that, it becomes a thread-like thing, like fibrin threads, you call it, mainly fibrin threads. So, this is your ropey discharge. This is a cue again, please. And when you examine the patient, what are the findings? Very, very important as in the exam. So, before that, we will first divide the whole disease as palpebral form, limbal form and mixed form. Mixed means both palpebral and limbal features are there. We did the same for trachoma, maybe palpebral padha tha, limbal padha tha. You remember? So, it's easy. So, again first is palpebral. When you say first is palpebral. So, when you say palpebral form, this is what you are getting. What is this? The raised papilla that is formed. This is what is called cobblestone appearance. Okay, when it is the papillary reaction is so severe, we call it cobblestone appearance. Right? Let's learn by drawing the diagram. That is the simplest way. So, we will make this diagram and learn the features. When you are saying palpebral, the finding in the palpebral conjunctiva is what? We are getting these raised papilla, papillary reaction, and this is what is cobblestone appearance. Q laga lena, this is an important exam question, cobblestone appearance. Okay, what is next? Limbal form. When you come to the limbal, again you get the raised papilla. So, you will get the same raised papillary reaction at the limbus as well. And we all know that the center of these papilla, you get central dots. I am putting it, okay, we can't mark it as white, so I am putting it like this. This is what is called Horner-Trantas spots. So, let me finish with the features and then we can see the slides. What are Horner-Trantas spots? Next question. So, this is also a Q, and another Q is what are these? We should know these are eosinophils. Okay, they are eosinophils. Next we talk about is there can be subepithelial scarring involving keratoconjunctivitis. It will involve the cornea, and this is what is called Cupid's bow. This is what is Cupid's bow. Okay, let's have a look before we move further. Okay, so let's see this one. So this is what? These are the mucoid nodules, you can say, which is seen on the upper limbus, right? Then what you see here is these spots, and this is what is called Trantas spots, right? This is the subepithelial scarring I am talking about, which is Cupid's bow. So, Cupid's bow is also called, it is also called pseudogerontoxon, because it's like a white, can you see it? It actually it is from here to here, right? It looks more like a Arcus senilis. So, it resembles Arcus, therefore, we call it pseudogerontoxon. And what is gerontoxon? Gerontoxon is another name of Arcus senilis. Therefore, we call this pseudogerontoxon. Okay. What next? Another finding is, you will see that because micro erosions are there in the cornea due to cornea involvement. Mucus gets stuck there, right? And some calcium phosphonate deposits. This is what is shield ulcer, right? So, this is also exam question, the straight question, if it is a feature of, you answer vernal keratoconjunctivitis. So, this is what is shield ulcer. What is shield ulcer? What did you learn? There are micro erosions. Over that is your mucus deposition, over that also calcium phosphonate deposition. Phosphonate deposition. Right? So this you have to keep in mind. Okay, let's draw this in our diagram there. So here also we should mark it. So let's mark here. This is your shield ulcer to complete the list. Okay, so next feature can be a pseudomembrane formation, which is nothing but the discharge between these hypertrophied papillae. Okay, so this is what is called this pseudomembrane, which is formed here. Okay, again it is mucus and fibrin and so on. This is what is called your Maxwell-Lewin sign. Okay, so let's learn it as Maxwell-Lewin sign. So just remember, what is Maxwell-Lewin sign? You will say it is pseudomembrane on the cobblestone appearance or pseudomembrane formation. Okay, so this is also a Q. So many Qs: cobblestone Q, Horner-Trantas Q, eosinophils Q, shield ulcer Q, and this is Q. Cupid's bow has not a Q, but you have to know it. It can be any type. Another question is, what a type of hypersensitivity reaction is this? It's simple. It's a eosinophilic reaction. So it is hypersensitivity type 1. Okay. Remember, this is type 1 hypersensitivity reaction. Okay. And what was mixed form? Of course, when both the features are there, this is your mixed form. We come to treatment. When you say treatment, it's allergic conjunctivitis. Nowadays, what we choose is a drug which has both the action. It's an antihistaminic also and it's a mast cell stabilizer also. What are the names where it is both antihistaminic and mast cell stabilizer? Let's note down. We will answer. First is your olopatadine. It has both the actions. So, olopatadine and azilastine. Olopatadine, azilastine. If you want to use only antihistaminics, we can go for epinastine. And another name, just know it, bepotastine. Only mast cell stabilizer action? Okay, let's now note that as well. When you say only mast cell stabilizer action, we all know it is sodium chromoglycate, isn't it? And or you can say lidochromyl sodium. Second can be lidochromyl sodium. You know this, right? Okay. So that was about this. Then of course for the mucus deposition, a lot of mucus discharge is there. So for the mucus, we go for acetylcysteine to dissolve the mucus. Let's note down here, to dissolve mucus, we can give acetylcysteine. If nothing works, I told you the last resort is always topical steroids, but they have to be particularly mild steroids. We don't want to land up into bigger complications. So note down, we prefer either fluoromethalone, okay, or you can use loteprednisolone. Good. Okay. So another important thing before, this was about vernal keratoconjunctivitis, but before we end the topic, there are 2 points more that you will keep in mind. Number 1, any excessive rubbing. So if we talk about excessive rubbing, whenever there is any allergy, if the child is rubbing the eyes excessively, there can be 2 major problems. One is it can be associated with keratoconus. Please remember, this is important fact asked. Okay, it can be complicated as keratoconus. And second thing that can happen due to excessive rubbing is folds below the lids, and what is that called? We call it Denny Morgan folds. I'll just show you what are Denny Morgan folds. So just remember this much. Have a look. This is what is. So can you see these folds below the eyes due to excessive rubbing? This is what is Denny Morgan folds. Okay. Next we talk about is atopic keratoconjunctivitis. Give the heading. So when you say atopic keratoconjunctivitis, these are the patients with atopic dermatitis. They are all prone for this allergy, okay, genetically associated, right? And mainly, what are the different points which are different from vernal? In vernal, it was mainly the male children. Here, there is no gender predilection, right? That was more common in summers, but atopic is more common in winter season, okay? It is worsening during winter season, and it is now more common in adults than in children. And of course, no gender predilection. Okay? Of course, when you talk about the clinical features, the keratoconjunctivitis, again, it's a lot of itching, watering. Okay, these 2 points we have to remember, that the patient is going to have a lot of itching and watering. IW is easy? Yeah. And when you examine the patient, the patient may be having the congested eyes, right? There can be conjunctival congestion. You may also notice associated cataract here. Which one is this one? Shield cataract. This is the shield cataract of atopic dermatitis. What are the associations I can see because of the excessive rubbing? What did you learn? This is Denny Morgan folds. That can be another associated finding is this one. What is this? Loss of 1/3 of the eyebrows. This is lateral 1/3, and what do we call this? Hertog's sign. This can be another feature of atopic dermatitis patients or the patient presenting with atopic keratoconjunctivitis. Okay. So, before I move further to treatment of atopic keratoconjunctivitis, we have to quickly also learn other causes of loss of this. What is loss of this eyebrows known as? Loss of eyebrow, this is called madrosis. If there is loss of eyelash, that is also called madrosis. So, madrosis is an overlapping term for both conditions. Please keep in mind. So, when you say loss of 1/3 of eyebrows, what are the main causes apart from this? Other causes, no doubt, is leprosy and myxedema. Okay, we will answer leprosy and myxedema, hypothyroidism, myxedema. These are the other causes of this Hertog's sign. Coming to the treatment. Treatment for this, of course, we can go to manage the allergy, we can go for the anti-allergic treatment that we have discussed. But apart from this, what we need here in case of AKC and sometimes in few cases of even vernal is cyclosporine eye drops, right? So, we use cyclosporine eye drops. We all know cyclosporine is an immunomodulator. So, this is all genetically managed now, you know it's a genetic disease. So, if this patient is having this problem, it's better to use these immunomodulators. It relieves inflammation in the eye. Secondly, you can go for tacrolimus, right? Again, tacrolimus is nothing but calcineurin inhibitor. That was about atopic keratoconjunctivitis. These are the points we'll remember. What can be the other associated conditions of atopic keratoconjunctivitis? Apart from the findings like shield cataract, we talked about Hertog's sign, we talked about Denny Morgan folds. A patient is going to have associated eczema because it's an allergy, he's prone to all the types of allergies, isn't it? Then allergic rhinitis and asthma. Okay, keep in mind. Talking about the treatment of this condition, in cases of acute flare-ups, we may need to give this steroids, mainly topical is mainly tried for if it is about keratoconjunctivitis, right? And apart from the steroids, what else we can go for is immunomodulators, especially in a chronic case. Then you have to go for immunomodulators like cyclosporine and tacrolimus eye drop. Just remember these are, what is tacrolimus? Is a calcineurin inhibitor. Okay, then next we talk about is vitamin A deficiency. What do you call it? Xerophthalmia. So, when we say xerophthalmia, let's first discuss what is xerosis. Xerosis means drying. We all know this. Now, when you say xerosis is drying, we will learn there are two types of conjunctival xerosis. One is epithelial xerosis and one is parenchymatous. Epithelial and parenchymatous. Epithelial xerosis occurs in your due to vitamin A. This causes vitamin A deficiency. The cause is vitamin A deficiency, and this is what you are calling it as xerophthalmia. when you talk about parenchymatous, all the conditions of scarring of conjunctiva is coming under parenchymatous xerosis. So, all the cicatrizing conditions of scarring of conjunctiva. So, we have to just enumerate what can be the causes of scarring of conjunctiva. All of you, number 1 of course is trachoma. Number 2, number 1 of course is trachoma. Then all types of burns. All types of burns means chemical burn, thermal burn, electrical burn, radiational burn. So, all types of burns. Third, Stevens-Johnson syndrome. Stevens-Johnson syndrome. And number 4, if you want to add, I am writing here, it is cicatricial pemphigoid. Cicatricial pemphigoid. These are some of the causes where you get scarring of conjunctiva. This is what is parenchymatous xerosis. Now, let us talk about xerophthalmia. How do you define it? It is a spectrum of ocular disease due to vitamin A deficiency. Let us think together. Vitamin A is a very important component of rods, right? So, initially what happens is difficulty in night vision, that is nyctalopia, night blindness. It is also a very important component for the health of epithelial lining of conjunctiva and the cornea. So, what happens when there is a deficiency is first the rods are affected, then the conjunctival epithelium, then the corneal epithelium, right? And finally, there are fundus changes. We can see it. So, initially the rods are affected and patient is symptomatic, but on examination finding and those spotted fundus will come little later. So, let us talk about, we will learn all these features by WHO grading of xerophthalmia. And of course, we know this is mainly in malnourished children, right, in developing countries. Now, we talk about is WHO grading. So, we are grading xerophthalmia as XN. X1 is divided as A and B, X2 is not divided, then X3 again A and B, and then XS and XF. What is XN? Night blindness or nyctalopia. Then there is dryness, that is conjunctival dryness. When there is extreme dryness, what do you call that? That triangular patch is Bitot spot, right? Then we come to corneal xerosis. Then comes X3A and 3B. 3A is keratomylation less than 1/3 of the cornea, and B is more than 1/3. XS is scarring and XF is xerophthalmic fundus. So, if you are used to writing like this, you can write it this way as well. Easy to learn like this, X2, X3, AB again, okay, then XS and XF. Chota lag raha, this one looks very elaborate. Anyway, so when you say first question, so you know these are the features, this is how the patient in sequence is going to present. Now, first question is, which is the earliest feature of xerophthalmia? I think it's obvious, earliest feature is nyctalopia. Done? Okay. Next is about Bitot spot. So, this triangular patch, dry spot, this is what is called Bitot spot, right? So, question is more common on which side? So, dryness will be more common temporally because the tear is draining nasally through the lacrimal drainage system. So, we should learn this as more common temporally. So, what you are looking at is, this is nothing but keratinized epithelium, starts keratinization. So, this is keratinized epithelium. Then they can ask you the foamy look on the Bitot spot. This is due to Corynebacterium xerosis. The foamy look in the Bitot spot, we will learn here, the foamy look is because of associated infection with Corynebacterium xerosis. So, these are the 3 points which are important for Bitot spot, right? Okay. Another question that they have asked you is, what are secondary and primary signs of xerophthalmia? So, very easy. What do you mean by that? Primary means it's only seen in xerophthalmia or vitamin A deficiency. Secondary means you can see this feature in other causes as well, other conditions as well. So, secondary signs easy to learn. We will learn it as secondary signs can be. So, this is the Q, okay? this is also Q, is easy to learn as XN, XS and XF. So let's think together. There are other causes of nyctalopia, night blindness. There are other causes of corneal scarring, corneal opacity due to scarring. Okay, and XF, we have other causes of white spotted fundus. That's what you get, white spotted fundus. So these are secondary signs, rest are primary signs. We can also note one thing here. One more point that you can note here is when you say xerophthalmic fundus, if we do an ERG, what we get is decreased amplitude on ERG. So we get a decreased amplitude on ERG. Both all the waves, that is mainly it is the rods which are affected, right? So which wave? A and B may A wave, but generally overall decreased amplitude. Another question they've asked you is about the pathological changes in xerophthalmia. If you talk about the pathological changes, 2 points we are going to remember. First, of course, is loss of goblet cells. This is what is happening, loss of goblet cells from the epithelium, the epithelial xerosis, right? That is why it is happening. And secondly, what is happening is squamous metaplasia with keratinization. So we are talking about in epithelium, it's an epithelial xerosis. What is happening in epithelium? Loss of goblet cells and squamous metaplasia with keratinization. Okay, so have a look. This is what is keratomalacia. What is keratomalacia actually? You can learn this as liquefactive necrosis of the corneal stroma. Okay, necrosis. So what is happening in this is liquefactive necrosis. We next talk about is how to manage xerophthalmia. So there is a vitamin A deficiency, you want to give vitamin A, please know the doses. Vitamin A, if your patient is more than 1 year, injectable vitamin A 1 lakh international unit is given on 0, 1 and 14th day. This is important, 0, 1, 14. This is asked in the exam, it's important. All of you, it's a Q. And if your patient is less than 1 year, half the dose. So if you have to give oral, so because oral absorption is of course limited, so we give double the dose of injectable is given for oral vial. That means if the child is more than 1 year, you were giving 1 lakh international unit. If you have to give orally, you give 2 lakh. If the patient is less than 1 year, you were giving 50,000. So oral, you will give 1 lakh. You understood? Yeah. In each case, we double the dose. Right. So that is how you manage a deficiency. You are going to give vitamin A. Apart from that, what is the topical treatment for the dryness that you are doing for the health of epithelium? You can use lubricating eye drops. Either it is a methylcellulose derivative, which is most commonly used, or it can be a hyaluronic acid derivative. And second, what you can do is give retinoic acid for healing of the conjunctiva and cornea, mainly retinoic acid. Okay, that was xerophthalmia. So many questions. Pitot spot, earliest feature, then treatment, then secondary and primary signs. Okay, remember all. Once we know this, we talk about what can be the other causes of night blindness. Apart from vitamin A deficiency, what is the next answer you should say is retinitis pigmentosa. Actually, this should be the sequence. You all know what is retinitis pigmentosa. This should be second number. Okay. First was xerophthalmia for vitamin A deficiency. For nyctalopia or night blindness, first cause. This sequence is important. I'll tell you till what. First is xerophthalmia, second retinitis pigmentosa. After that, you say whatever you want to say. So, retinitis pigmentosa, we will learn in detail in retina chapter. It's a dystrophy of rods and cones. Okay. You remember what is a dystrophy? I taught you in the cornea also. Any idiopathic spontaneous change with no inflammatory component is dystrophy. What is the next cause? High myopia. What is high myopia? High myopia is defined as any myopia of more than 6 diopters. So, this is your high myopia. Number 3 and number 4, late stage of which glaucoma? Primary open angle glaucoma. This is a factual thing that you get night blindness in late stage of primary open angle glaucoma. Right? Again, you can relate it to so much of the optic nerve damage is causing some problem. Then we talk about next is what are the other causes. ठीक है, ये तो 4 अच्छे से आने चाहिए. Xerophthalmia, retinitis pigmentosa, high myopia and late stage of primary open angle glaucoma. Now you think of some causes which is fundus related from the retina. Very important, congenital stationary night blindness. When you say congenital stationary means non-progressive. It is not progressing, it is stationary, so it is non-progressive. Two conditions that we will learn. One is fundus albi punctatus. What is albi? White dots. So, this is night blindness with white spotted fundus. Fundus albi punctatus. Second is Oguchi's disease. So, here what are you seeing? We see again night blindness with pale fundus. What is pale fundus? It is not looking normal red, it is yellowish. This is what is, as you can see here, Oguchi's disease, which is congenital stationary night blindness with pale fundus. You should know this much only, okay. Then we talk about what can be the other causes, choroidal causes. So, these are the two choroidal dystrophies. Choroideremia and gyrate atrophy are choroidal dystrophies. So, we have question on Oguchi's disease, we have question on gyrate atrophy. Let us learn it. So, Oguchi's disease, the question is, what is Mezo's phenomenon? The other name is Mezo's Nakamura phenomenon. Full name is Mezo's Nakamura phenomenon. Let us understand. So, this patient is having what problem? Night blindness with pale fundus. Now, you ask this patient to sit in dark, make him sit in the dark for 1 hour. Okay? Sitting in dark for 1 hour. What do you see? No night blindness, that means he starts seeing, he is able to see, and fundus is normal. Now, the fundus is not pale, fundus becomes, that means whatever the problem was is reversing. This is what is Mezo's phenomenon. The question of your exam was, it is a feature of, and you had to answer Oguchi's disease. Okay? So, why this is happening? These are the patients who have less number of rods, but why this is happening is, when they are sitting for 1 hour in the dark, there is overstimulation of rods. Okay, the cause is overstimulation of rods. Okay, come to the next question. Gyrate atrophy. Gyrate atrophy is in what? I told you it's a choroidal dystrophy. These changes in the choroid, they will occur because of what? There is a deficiency of enzyme ornithine aminotransferase. So, it is a disturbance of urea cycle. So, when this is so, what changes you get is atrophic patches on the choroid like this. This is what is gyrate atrophy. Got it? And have a look. So, these atrophic patches, this is what is gyrate atrophy, and when it is all around, this can lead to important point here, that is constriction of visual field. You have learnt with me that one of the causes of tunnel vision can be gyrate atrophy. It can lead to tunnel vision. So, this is one point we will remember. Of course, next we remember that it is due to deficiency of aminotransferase. Question was, what is the treatment? Arginine free diet. So, this is your question. Because why? Arginine is a precursor of ornithine. Remember that. So, the patient is kept on arginine free diet, and sometimes some patients with vitamin B6 supplementation can benefit from this condition. But yes, question was on arginine free diet. Okay? Okay. We talk about what is day blindness known as. You know, hamarlopia. Day blindness is hamarlopia. Now, when you say day blindness is hamarlopia, think yourself, daytime, when can there be blindness in daytime? Pupil is constricted. So, any opacity which is at the center can lead to day blindness, whether I am talking about central corneal opacity or central lenticular opacity. And of course, you know, it is the cones which are responsible for day vision and color vision. Therefore, the third cause will be congenital absence of cones. So, what are the points? 1, 2 and 3. Just remember why. This is about day blindness or hamarlopia. We come to the next heading, and that is your pterygium. Now, pterygium, again we will make a queue here only. So many questions from pterygium. What is pterygium? I don't think anybody can misdiagnose this. It is a triangular tissue which is subconjunctival fibrovascular growth encroaching the cornea. You can see this here, it's encroaching the cornea. So let's note down that it is a subepithelial fibrovascular growth, okay, over the cornea. Question of etiology first, and this is your exam question. Etiology, what is the main etiology? Why it is happening? So it happens, it's more common in tropical countries where there is exposure to ultraviolet rays. So this is mainly due to UV rays. They have asked you which UV. Is it UVA or UVB? So we all know we are talking about UVB rays. Okay. So this is number 1. Secondly, it is more common on which side? This is also exam question. More common nasally. Third point, is it mainly, this is also exam question, whether it is inflammatory or it is a degenerative pathology, right? So it's mainly a connective tissue disorder, or you can say degenerative. It is not inflammatory. Okay, so this has been asked in exam. We will learn it is not inflammatory. It is mainly a degenerative or connective tissue disorder. Note down. And then if you talk about pathology, we will learn what is happening here is elastotic degeneration of conjunctival stroma. Okay, so there is elastotic degeneration of the conjunctival stroma. The same pathology applies for pinguicula, the same for pterygium. That's interesting, isn't it? So, easy to remember. Then next question is, okay, instead of question, let's discuss what is the clinical feature. How will this patient present? So, the patient will not be bothered about it for a long time. He can present to you if there is some cosmetic issue, that what is this white patch on my cornea. Or they can, if it is growing further, lead to astigmatism, that is alter the curvature of the cornea. And third, as you can see here, if the pterygium is growing further into the pupillary area, it is going to lead to diminution of vision. So next we will learn is diminution of vision if encroaches the pupillary area. That is the clinical feature. Now, what are the other things that we will know? If you look at the pterygium, right, on examination, when you look at the pterygium, what you see, this pterygium has, what are the parts of pterygium? This is the body of the pterygium, right, and this is the head of pterygium, and there can be a halo, a slight halo just in front of the head. This slight halo can be there, which is called the cap. This is called cap, right? Okay. Lastly, exam question, there can be deposition of iron along the head of the pterygium, and this is what is iron deposition is called Stocker's line. We have learned this. This is iron deposition. This is called Stocker's line. So now we know that pterygium has a body, a head and a cap. So when you say that halo or the cap, it is mainly due to destruction of Bowman's membrane. Remember this, it is destruction of the Bowman's membrane by metalloproteinase. This may not be asked, it's a little extra point. If you don't want to remember, it's okay. But Stocker's line, you cannot forget, please. Okay. Now, before I move further, one more thing to discuss is UVB rays, you are just saying that causes pterygium. What is the other effect of UVB? They can ask you. They have asked you. So, other effect is, remember anyone? Photophthalmia. What is photophthalmia also known as? It is also called snow blindness. Why? Because what happens when you are in the snow at a height, ultraviolet rays from the snow can reflect and injure your eyes. That is why we call it snow blindness. So, snow blindness of photophthalmia is nothing but injury by ultraviolet B rays. What does it cause? It leads to corneal epithelial erosion, and this epithelial erosion can be managed by, how do you treat it? Of course, this is a very painful condition. Eye cannot open even in a small erosion, and this whole epithelium gets eroded, right? And then treatment, of course, is simple, that you have to just bandage the eye with antibiotic ointment. Okay, pad and bandage with antibiotic ointment. Okay, at this point we will also know what is photoretinitis. So, photoretinitis is injury to eye by infrared rays. Injury by infrared rays. This is called photoretinitis. So, when will this happen? This happens when, so snow blindness is happening when you are not using any goggles, no UV protection, and you are going in at a height, this can happen. Why will this happen? Photoretinitis, directly looking at the solar eclipse with unaided eye, no filter, and you watch solar eclipse, okay. So, when you are looking at the solar eclipse with unaided eye, you can get photoretinitis. क्या होता है इससे? Infrared rays can actually damage your macula, leading to macular burn, and this macular burn will lead to macular scar. And treatment, no effective treatment. How can you treat a macular scar already formed, right? So, no effective treatment. Then do you all know also what is pseudopterygium? Any tissue, scar tissue which is resembling like a pterygium is called pseudopterygium. So, another exam question is how to differentiate pterygium from pseudopterygium. You will answer glass rod test. What is glass rod test? You try to pass a glass rod below the tissue, below this lesion. So, please remember, and again this was debatable, but no debates here. This is confirmed. You have to learn this only, that when it easily passes, this is pseudopterygium. So, if it is passes easily, this is pseudopterygium, because pseudopterygium is only adhered at the apex, okay, at the head, at the apex of this. Whereas, when it is not passing, then you will say now this is pterygium. If it is not passing, it is pterygium. This is what is glass rod test and hazard exam, right? So, we will write it here that treatment is excision. Let us draw and understand, but because if I am just leaving a bare sclera, just suppose there was a pterygium here, the dotted lines, I have removed it, I had created a bare sclera. This is called bare sclera technique. But as I said, it has a high rate of, please keep writing, high rate of recurrence. So, the next question, another one, is how to prevent recurrence. So, to prevent recurrence, there are two measures I can take. Either I use mitomycin C. Okay, if I use mitomycin C at the lesion, at that area, after removing, sometimes peroperatively it is done by, that is putting it for some times on the sclera after excising the tissue. But again, there is a high risk of scleral necrosis. We have to be very careful with the stopwatch, or sometimes it is given as a post-operative eye drops. So, whatever it is, we can go for mitomycin C, number 1. But because as you can see, there are complications here, the next is autografting. So, the question is, which one is the best method to prevent recurrence? Best method will be autografting. Note down, this is the best method to prevent recurrence. Come back to the diagram. What is autografting? We are cutting a block of the conjunctiva from here. We are dissecting further to involve the limbal stem cells. This is the X side of the graph and this is the Y. Just take it and stretch it on this area where you have excised the pterygium. Again, X has to be, we have to be careful that this is the graft, then X is on this side and Y is on this X. Why? Because you want limbal stem cells to be transplanted on this side. This is what is autografting. This is the only point we have to be very careful about, is the X should be stretched at the point of the X. This is autografting. This is much better than mitomycin C. This is your exam question. Third thing, recent question exam is what is perfect surgery? So let's understand, if suppose I am over N2 and I create a larger area of Bayes sclera up to this much, then in order to cover this, I will need a little larger graft like this. This is what? This is what is called perfect surgery. It stands for pterygium extended resection. So we have extended it, followed by extended conjunctival transplantation. So if you've understood this method, you will understand the full form. Okay. So understood? So perfect surgery kya hai? It is P, there should be a dot here. It should be written like this. This is perfect surgery is actually full form is pterygium extended resection followed by extended conjunctival transplantation. Okay? And then wide view, it's a perfect surgery also because if I follow this, why I am doing this, why I am cutting such a large area? Because we have seen that the recurrence rate is only 0.1%. So almost it's perfect only. Okay? Whereas in case of Bayes sclera technique, it was 37 to 40% of recurrence rate, 37%. So that is why this is a better method. So question kya aaya tha? Perfect surgery is related to, and the answer was pterygium. So that this was about pterygium, and these were the questions. I hope you realize how important this topic is. We next talk about is what is pincicula. We know pincicula is nothing but a yellowish raised lesion near the limbus like this, right? So this is what is pincicula. It looks yellowish, but it has no fat. Resembles like a fatty tissue, but there is no fat. Again, what is it? We have just mentioned this. It's elastotic degeneration of conjunctival stroma. The same pathological change as we have studied in pterygium. Generally, it is innocuous. It is not causing any problem and we don't do anything about it. But if there is some inflammation and irritation, which we call as pingiculitis, if it is symptomatic, I will treat with mild steroids and lubricants. Otherwise, we don't need to bother about it. Sometimes for cosmetic reasons, if the patient is very much after you, you may go for surgical excision. It is a possibility. If he is too much inclined that he wants to remove this, right? And again, one question. It is more common, just like pterygium, more common nasally. Again, it is more common nasally. Okay, next we talk about is dry eye. First thing is about the tear film. What are the layers of the tear film we know? Over the cornea, lowermost is mucin layer, right? Mucin layer, we all know, understand, cornea, then the tear, we are talking about mucin layer. What is the role of this mucin layer? It spreads the tear on the ocular surface. Isn't it? Understood? Right? So, by decreasing the surface tension, it is helping to spread the tear on the ocular surface. Normally, what happens if the water is falling, it becomes a drop due to surface tension. Padha hai na physics? So, this is what mucin is doing, right? Next layer is your aqueous layer. What is the role of aqueous layer? Main lubrication role is aqueous layer. This is causing lubrication, mainly responsible for all the lubrication that is needed by the tear film, majority of it. And what is the next layer? Next layer is your lipid layer. Lipid layer, what is the role of lipid layer, all of you? Lipid layer prevents evaporation of the tear because there is a layer of lipid over it. It prevents evaporation of tear. Okay? So, aqueous causes lubrication. This is preventing evaporation and this is spreading the tear on the ocular surface. So, mucin, aqueous, lipid. Right. We also talk about from where they are formed. So, from where the mucin is formed, we should know goblet cells of conjunctiva. Where are the goblet cells? Epithelial layer. And I have taught you, does goblet cells are maximum where? You will answer inferonasal quadrant. And where are the goblet cells minimum? If by chance they ask you, you will answer minimum superiorly. Talking about the aqueous layer, this is formed secreted by lacrimal glands, and let's add here accessory lacrimal glands. Lacrimal and accessory lacrimal glands, they are secreting the aqueous layer. And what is lipid layer secreted from? From where is lipid layer secreted is meibomian glands. Meibomian kahan present hai? In the lids. Right? So, this is about your tear film. Now, deficiency of any of these three layers is what is called dry eye. So, what is dry eye? Dry eye means deficiency of any of the three layers. And what is dry eye disease? Dry eye disease means due to this deficiency, when you start having inflammation, ocular inflammation. Okay? So, when it starts causes ocular inflammation, now this is called dry eye disease. What is keratoconjunctivitis sicca? So, very important, please remember KCS is of course dry eye, but be specific, it is deficiency of only aqueous layer, right? This was important exam question. Mucin layer deficiency is seen in first option KCS, everybody mark KCS. Okay, dry eye hai to KCS. No, in KCS there is only aqueous layer deficiency. So, that's the trick. And of course, we all know what is dry eye with dry mouth known as, we call it primary Sjogren's syndrome. And when it is associated with connective tissue disorders, we call it primary is associated with connective tissue disorders like rheumatoid arthritis. Then we call it secondary Sjogren's. Okay. Next, we talk about what will be the clinical features if the patient complains of facing dry eye. Very important, burning sensation. Okay. Number one, burning sensation. Then gritty sensation or something pricking in the eyes. Why? Because it doesn't have inner tear to drain the debris and mucus from the eye. So, therefore, there is excessive mucus deposition, and therefore, when it is affecting the precorneal tear film, that means the layer over the cornea, it can lead to marked diminution of vision. Okay. So, burning sensation, gritty sensation, more of the mucus deposition, and severe cases may, that is diminution of vision. Okay. On examination, first thing you will see when the patient is coming to you, number one, please note it down one by one. This is your increased or decreased tear meniscus height. So, tear meniscus height is less, decreased tear meniscus height, TMH. So, the point is, what is the normal value? Normal value is 0.2 millimeters to 0.4 millimeters. So, on slit lamp, when I am looking at this, it should be this much, but anything less than 0.25 millimeters is dry eye. Less than 2.5 millimeters is dry eye. We come to the next finding. Next finding is, look at this. This is what is epithelial, punctate epithelial keratitis. So, you may get these punctate lesions if especially the precorneal part is involved. Number 3, we may get all these mucus deposits. Filaments are all deposited, excessive mucus deposits, right? And of course, this is again the mucus filaments, right? These are the findings for dry eye. Now, how to confirm? Investigations, again very important as in the exam. First is your Schirmer's test. One by one we will take. First is Schirmer's. Schirmer's test is nothing but when we use Whatman paper number 41 on the lower lid, it has markings in millimeters. You keep it there for 5 minutes. And after 5 minutes, you will see how much of the paper is wet, right? See here, it's already marked. Anything less than 5 mm means severe dry eye. And normal is how much? 15 mm. This much wetting we expect. So, 15 mm is normal. Anything less than that, we will consider it dry eye, right? And severe dry eye is less than 5. Now, another important thing is what is Schirmer's test 1 and 2? 1 and 2 means Schirmer's test 1 is what? Schirmer's test 1 means that I am measuring and doing this test without any topical anesthesia. When I am doing it without any topical anesthesia, I am measuring both basal tear production and reflex tear production. Okay. This is your Schirmer's 1 which we are doing. And what is Schirmer's 2? 2 means only basal is measured because under topical anesthesia, because you are using a topical anesthesia, right. This is Schirmer's 2. And what are you measuring? This is also asked in the exam. We are actually testing the volume of tear. Okay, tear production of, or the volume of the tear is being tested. Now, suppose you don't want to wait for 5 minutes, you want it to happen very quickly, we can go for phenol red thread test. What is phenol red thread? The red thread is coated with phenol red, okay. Put it in the lower lid, this time only for 15 seconds, and any wetting of less than 6 millimeters. This is considered significant dry eye. So, there is a change of color due to the change in the pH when it is coming in contact with the tear, and that change in color is from yellow to it becomes orange or red or orange. Okay, from yellow to orange due to change in the pH. This is what is also, this is also exam question. Okay, so this is also a Q. Phenol red thread test. We come to the third test. Third is BUT, breakup time. Right? What is breakup time? How much time it takes once you have once you are blinking and then you stop blinking. After the blink, when you start staring, how much seconds it takes for the first dry spot to appear on the cornea. So, you are examining the patient in the slit lamp with a mild fluorescein you have put here, and you are just examining in the slit lamp. These are the dry spots we see. So, let us learn how to do it. First dry spot. So, from the last, the time which is measured is from the last blink to first dry spot. Okay. Right. So, if it is less than 10 seconds, again this is significant, considered as a dry eye. What are you measuring here? It's of course phenol red thread is the same as your Schirmer's test. We are again measuring the volume of tear. Right? That is mainly which layer deficiency we are talking about? Aqueous layer. In this case, breakup time, we are measuring the lipid layer, primarily the lipid one, okay, and also aqueous production, lipid and aqueous production. So, if the lipid layer deficiency is there, you will get a quicker dry spot. Now, what we have to keep in mind in this test is that you should be repeating it for at least 3 times. Why? Because if you see that the dry spot is appearing on the same spot every time, that means there is some surface problem in this patient. The corneal surface there is not smooth. This is the reason I am getting a dry spot there. In this, if it is so, then it is not a reliable test. Okay. So, you should do it at least 2 or 3 times to understand whether it is the dry spot is appearing on the same area and the same spot again and again, or it is appearing on the different places. Right. What is the next investigation I can do, of course, is staining. So, we have learned that rose bengal and lysamine, they stain dead cells and mucus. Right. So, in dry eye, it will stain the dried up dead cells and mucus. This is your rose bengal staining. Now, when a severe dry eye, the typical stain of the rose bengal, when you look at, because everything is dried up, looks like 2 triangles with the base at the limbus. This is a feature for severe dry eye. Just know it. Sometimes they ask. 2 triangles because the area after your cornea is all triangular only, na, either side. Chalo. Then another I told you, but what is the main disadvantage of rose bengal? So, staining is being asked again and again recently. Please remember, when you talk of dry eye, I would still avoid rose bengal because it stings a lot. stings a lot and therefore avoid it. What I will choose is lysamine. I'll choose lysamine green because this also stains dead cells and mucus only. Okay. So, I do it with lysamine green. And if I have to see the corneal changes, of course, then it is fluorescein. So, they have asked you the sequence which you will choose first. Practically, we use fluorescein first to quickly see any corneal changes or not, but ideally, theoretically, if I am focused on dry eye, I should go for a lysamine green, then fluorescein, last resort should be rose bengal. So, that should be the answer of your question, right? Okay. What are the further investigations you can look for is, we can see the tear osmolality measurements. If the tear osmolality has to increase in patients of, it increases in dry eye. Tear osmolality is more in dry eye. Whereas, we can go for tear constituent test, lactoferrin levels are seen to be low. So, low lactoferrin. Okay. And thirdly, what you can go for is impression cytology to see the number of goblet cells. And yes, of course, tear meniscus height can be even measured through optical coherence tomography. This is tear meniscometry. So, these are some further investigations that can be done in a patient of dry eye. So, dry eye has become a very, very common thing, isn't it? So, these days dry eye is, because the screen time has increased. We stare so much on the screen, we forget to blink. This is the main reason that we are facing this dry eye problem, right? So, and if it is a severe, if it increases and becomes severe, it's really a very, very big hassle. It's not a small thing, okay? So, we have to be careful. Please learn to blink, please have a little less screen time, it is going to help you more. Yeah. We come to the treatment part. So, we know any dry eye can be medical or surgical. What can be the surgery in for dry eye? Can you think of any surgical treatment for dry eye? What do? We use all the measures to retain the tear that the patient has. That means, we try to see that the drainage is less and less. This is the surgery we can do, that is lacrimal punctal occlusion. Okay. So, first we talk about medical. Medical, of course, lubricating eye drops. Most commonly used as asked in the exam, we all know it is methyl cellulose derivatives. We can use povidone polyvinyl alcohol combination or hyaluronic acid combinations. Secondly, of course, acetylcysteine to dissolve mucus. This is to dissolve mucus. And if we have inflammation, it's a dry eye disease, we may want to use cyclosporine. Okay. And of course, if there is an any associated lead pathology, that should be managed. Okay. So, this was about your medical. And as I told you, for surgical, it is lacrimal punctal occlusion. When you talk about lacrimal punctal occlusion, temporarily I can do with collagen plugs, which are going to dissolve with time, or I can use silicone plugs, which need to be removed when you don't want it. So, these are all still temporary. But if I have to go for a permanent, then I cauterize the proximal caniculi. Proximal caniculi is cauterized. This is the permanent method of doing a lacrimal punctal. That area and that path is all blocked, so that the tear stays for a longer time in the eye, right? So, that is the mechanism. Okay, right, all of you? So, that was about your dry eye, and that was about your chapter of conjunctiva. Hope you enjoyed with me. So, let's first solve few questions. So, these are just the MCQs for you to recap, see whether you can answer these very, very simple ones. Which of the following is the most common cause of ophthalmia neonatorum? I have taught you it is chlamydia. What is the treatment strategy for trachoma as per WHO's? What is the safe strategy full form? I hope you know it is this one. Surgery, antibiotics, facial hygiene and environmental cleanliness. Actually, it should be very, very accurate. You should be saying environmental cleanliness. Okay. Next we talk about is, next question is, Stocker's line is associated with which of the following conditions? We know we are talking about iron deposition at the head of the pterygium, where you get Stocker's line. Okay. Which orgasm is most commonly associated with flectennular keratosis? Most common, we will answer staph aureus. Right?